Now we will begin the panel discussions. Our first panel is about digital care for a healthy future. What will the future of digital health look like? That's an interesting topic. The pandemic has radically accelerated the adoption of digital health technology, given further impetus to long-term trends that were already underway. Digital transformation is now top of mind for healthcare leaders, and they seek to build resilient and future-proof healthcare systems. Yet challenges remain. The panel, moderated by Padma Shri Professor Dr. Sanjeev Bagai, will discuss how technology powered by AI and ML add value to the health economy and create positive impact on the growth and the development of the healthcare sector. We have with us Dr. Arvind Lal, Chairman and MD of Dr. Path Labs, Dr. Rajiv Singhal, Founding Member, Managing Director and CEO, Marengo Asia Healthcare, Mr. Raj Gore, who is the CEO of Healthcare Global Enterprises Limited, Dr. Sushil K. Meher, he is the head of Health IT, AIMS, New Delhi, Manoj Warrior, Vice President, Technology Engineering, Providence, India. To discuss this very pertinent topic, may I invite all of you onto the dais. Dr. Bagai, the floor is all yours.
So just a brief capture as an introduction, and then I will ask each of the panel members, perhaps the best minds in this space, to say a few words as their opening comments. And then we will break this discussion up in 5 or 6 major verticals, because the digital front is so vast and wide. We will not be able to do justice if we do everything under the sun, but we'll pick up the major verticals and we'll get inputs from all our esteemed panelists. Just as a quick brief, India is occupying just 2% of the global landmass, 21% of the disease burden globally, and 20% of the world's population. We already have an ongoing deficit of more than 2 million short of beds, 1.5 million short of nursing staff and doctors individually. The geographic spread, the language spread and diversity, lack of connectivity and last mile coverage, especially in the hilly regions of the northeast and the north, and the specialist deficiency ranging between 27 to 35% of the super specialists gives a great opportunity where the digital platform and smart technology come in to bridge this gap. Not to mention the aspect of this in medical education. The misconception is very often people say as doctors, medical professionals, administrators that my hospital is digitally smart. Why? Because you have an electronic medical record. Wrong. That is just one amongst the almost 120 to 130 portals and verticals of what digital smart technology means. The real key towards having a digital smart technology, and the real question is, why would you like a digital smart technology? And we will build the story from here. I will request, beginning with Dr. Arvind Lal, just a quick 30-second introduction of yourself, and then we will start the discussion. Arvind first, please.
Good morning, ladies and gentlemen, and thank you very much, Dr. Bagai, and thank you, Blue Star, and thank you, ITB. For getting me here. So the importance, about something about myself, we are not as old as Blue Star, but almost there. We are 73 years old also. And we started the lab just across the road, across Parliament Street on Hanuman Road. And I joined the lab in 1977 after the demise of my father. We've been there now for many years, as you can see. So currently we are running about 280 or 84 labs, about 5,000 collection centers, about 10,000 pickup points, like a hospital is a pickup point, an Apollo hospital or a Medanta. So 10,000 points like this. And last year we carried out testing on about 2.87 crore patients, which means on an average day we can test more than 100,000 patients. So I'll come to the technical part later, but we were lucky to introduce IT for the first time in healthcare in India in 1986. And since then, we haven't looked back. So I'll come back later. Thank you, Sanjeev.
Thank you. Thank you, Dr. Bagai. Thank you, Healthcare Radius, for organizing this event. And it was a chilling presentation from Blue Star as well. So I'm Dr. Rajiv Singhal. I was surgeon in Indian Army for 14 years before I moved into this entire world. Been to the chilling places like Siachen, where it was minus 38 degrees, so Blue Star was missing there. And after that, worked in the corporate world of healthcare, Ruby Hall, then was in Fortis for a good 5.5 years, ran Fortis Escorts Heart Institute, private equity world, then Care Group of Hospitals was my last assignment as Group CEO. And in October 2020, we are not as old as Dr. Lal Pathlab or other people. We are young, naive in the healthcare world, started this organization, founded this from the flat where we stay in Gurgaon, raised the fund in October 2020 in COVID times. Today we have 3 investors, Samara Capital, Family Office of Godrej, and Family Office of Havels. They are the investors. Our objective is to build a 5,000 plus bed platform in next 3 years. Presently, we have 1,300 beds with us, and we aim to cross 2,000 or 2,500 beds in next 3 to 4 months. So this is where Meringue Asia stands as of today. Thank you for giving this opportunity.
Doc, please.
Yeah, I'm Dr. Sushil Meher from AIIMS New Delhi. I'm thankful to the organizer to have in this panel discussions. Everybody knows about AIIMS, but the journey of IT has started from the day one when the AIIMS has established. We have done the paper tap as a storage from the day one. Right now, we have 5 petabytes of data in one place. So this is our journey. But the future of the AIIMS, what I am going to tell you, we have come up a new center. It is National Cancer Institute. This is the one institute what we have for the cancer. It is 350 acres of land, and it is in the out of the campus in Jhajjar. It is a state-of-art building, and beside these centers, there is another 200 acres land has been allotted to IIT Delhi for the second campus, because we have to do the research. Okay, and this center has already been signed the MOU with NCI USA, with the Honorable Prime Minister Narendra Modi and Barack Obama. So this is the kind of institute it has come up. It is operational. It is 750 beds, and all the data it is will push up from the Jhajjar to the main hospital with the lease lines. These are the technology which has been there. Later I will discuss. Another new thing which is coming up. Right now we have 3,500 beds, and within 4 years it is going to be 7,000 to 8,000 beds. New centers, new geriatric centers is coming up. It is dedicated to the old age people. Surgical block it is come up with another 700 beds. Specialized transplant it will be there. Another center has come up, mother and child. Another center has come up, it is the gastroenterology and liver transplant. Another center, already it is operational, that is a burn and plastics. So there is a lot of very specialized setup which is coming up within the campus and out of the campus.
Thank you. Thank you. Please, just a very quick introduction, please.
Hi, I'm Raj Gore. Thank you, Healthcare Radius, for having me. Thank you, all of you, for joining today. It's an honor to be part of this panel. I have fortune and pleasure of driving the 2 most exciting, rapidly evolving agenda items, cancer treatment and digital transformation in my organization, Healthcare Global, which is the largest cancer care provider. And what I'm most proud of, I think we are most inclusive cancer care provider who is present in 18 cities and 8 states in India. Thank you.
Hi, ladies and gentlemen. This is Manoj Warrior. I am basically a technologist, and I have over 25 years of experience in doing digital transformation for multiple sectors. I've done it for retail, done it for software.
Dr. Maidu.
It is an honor to do it in healthcare as we start, because healthcare is the last bastion who is getting into the digital age now. And it is great to be here, and I represent Providence, and Providence is one of the, is the only healthcare tech which is trying to transform healthcare for US healthcare systems. We are around 52 hospitals, and we have actually started this journey around 2 years ago, and we are very much on focus for the transformation.
Wonderful. So let's build this discussion as a story as it unfolds. The first question is, why would someone embrace digital technology? So technology is one vertical and digital smart is another vertical, which both combine to give you a digital smart technology. And I will ask each of the panelists to give an introductory remark now focusing just on this. So for me, any technology which gives better clinical results, what we call as clinical excellence. Point number 2 gives operational excellence. Point number 3, a better patient experience. It gives cost of treatment at a lower value. That means a cheaper treatment to the patient. It gives you results which are better and is patient-centric, is digital smart technology. I will request, beginning from my gentleman right at the extreme, what are the key points? Why would you embrace digital smart technology in an institution which you are working in or want to build up?
Absolutely.
Just keep it brief to 1 or 2 minutes so that we can have multiple rounds of aspects.
Sounds
Please.
good, doctor. Ideally, I think the digital technology has to be embraced in healthcare. You know, it is imperative. It is not a good to have. We have to get into digital technology, the digital transformation for healthcare, especially with the hyper-connected world which we are in, and the consumers or the patients need it in a click of a button, right? We are moving into a state where people want it self-serve and always available on demand. So definitely, if we don't get into that age, we are going to lose this race very quickly. So it has to be transformed.
Next, please. Yourself.
So I'll talk about cancer treatment. It's a thousands of years old adversary disease we are trying to understand and treat. And we made a lot of progress, and you know, Siddharth Mukherjee has captured it very well. But you know, if you look at last 2-3 decades, we've started specialization on organ or site specific. But now we know that with the power of genomic sequencing, you're going to treat a genetic mutation, you know, that may be same for breast versus, you know, cervix versus some other. So it's becoming personalized, precise, but at the back of it is molecular imaging and genomic sequencing. A human genome is about 60 to 100 GB of data. Now you add to that, you know, molecular imaging data, you add treatment data, the drugs, and then you add a longitudinal dimension, once a cancer patient, a lifetime cancer patient, and you add all that, you know, electronic medical record. And think about the information that we have and the processing power that we need. And I'm sure if we apply AI, ML, it will point us in directions which will evolve cancer treatment, you know, in a more personalized and precise manner. So that's why, you know, for us, it's one of the focus area.
Wonderful. Adi, please.
So I think Raj very well said, and I think he's bang on saying that how valuable this data and then use of AI and other things. But having said that, I just step back and talk about why we think it is far more important for technology to be adopted, and especially IT technology. If we go back in the evolution of healthcare, NASA was developing the cameras which can actually look at the surface of the moon long time back. Light travels in straight light. It was difficult for people to develop something where they could see the surface of the universe at that particular time. They developed something called as rod lens system. Endoscopes is a classical example of that NASA technology, which they worked with Johns Hopkins and got that. Healthcare has always been chasing the technology. It's not that we haven't done it. The only thing is IT, we have been slightly slow in adopting technology. The consumer world has moved very fast. Today you can actually buy anything sitting at a home from the power of your cell phone. But I think it's not late for us. It is important that the consumer has changed the behavior. We should stop considering our patient as a poor patient. It's a tech-savvy patient. patient understands what is changing in the outer world, it's important for us to embrace technology sooner than later.
Next to Arvind, I think Arvind has, Brigadier Arvind Lal has the largest and the most expansive network of radio diagnostic in India. Your initial introductory comments on the technology which you have embraced to enhance patient care.
So, I think first thing first, let's talk about the current scene. I would be failing in my duty if I did not single out one, effort from the government, and that is this ABPMJ, or during the COVID, the Co-Win, platform. And I must put it on record that this has, it's a mind-boggling kind of an exercise. All of you know that 180 crore Indians have already been vaccinated, and each one of them gets a report within absolutely no time. The moment he's jabbed you, almost 15-20 minutes later, you get something on your cell phone, etc. So I must thank this government. We're not politicians, but what is good is good. And now these days it is led by Dr. R.S. Sharma, who is the CEO of the NHA. So I think first we must give them some credit that they got it right. So from our point of view, the digital technology has, it's taken for granted that we have to adopt it. And in India, where we are already short of 10 lakh doctors and 1 lakh specialists, not to talk of 20 lakh nurses and 30 lakh paramedical people, you cannot survive without digital technology. In pathology itself, we have about 300,000 labs in India, and the number of pathologists are not more than 7,000 or 8,000. So whether we accept it or not, but telemedicine or telepathology, teleradiology is the writing on the wall. So I would like to emphasize that the necessary regulatory changes and the rules also have to be brought in. It's not good enough to just discuss it in nice air-conditioned halls, but a lot of to and fro discussion has to go on. The second thing also I would like to point out is that the non-communicable diseases in India, which are killing 65% of our countrymen, they cannot be controlled unless you bring in digital technologies, whether it is testing or whatever, and treatment. So you can imagine that in India, about 42% of diabetics don't know that they are diabetics, and about 56% of hypertensives don't know that they are hypertensives. So whether it is going to be futuristically a digital wearable technology or IoT or whatever you may, we can talk about these things. And but the fact of the matter is that somebody has got to kickstart it. The third thing which I'd like to mention is that there's no point in talking about all these things futuristically, when a simple electronic health record is not available in many big hospitals, including that of the government. So, of course, we've heard of e-Sanjeevani, we have heard of now internet, connectivity, etc. Reliance is there, Idea is there, etc. And Starlinks is there from Amazon. So all those kind of things, are there, but a simple thing like an electronic health record is still not available to the common man. Imagine a common man who stays in, say, Calcutta. He goes for his, to a holiday to up north, somewhere in Simla. He falls sick, and he goes to the Indira Gandhi Medical College in Simla, and he goes. His, record should be available there, with the Aadhaar card number or whatever, thing is. So these are very small things. The private sector has been doing it. The government, with what I mentioned to you, has already done much more. So this should not be difficult, except for the fact that the government said that they are only, creators, they are only pathfinders, they are not the actual providers. So I think I will stop here, and next I will show you a slide which I have brought with me.
Before we come on to Doc from AIIMS, I think we moved away from the famous 3 A's of affordable, accessible, and accredited healthcare, and we are now moving to the big P's, which are preventive, primary, personal, predictive, and precision. When you mention this, I think it's what Arvind has mentioned, it's a huge, huge effort on the Indian government to cover 194 crore vaccines today, as per this morning. Perhaps the largest, safest, and the quickest vaccine campaign the world has ever seen. Not only the CoWIN app, but the overall implementation, and also a remarkable effort of all the medical professionals, and a small prayer to all the medical professionals who actually died during this COVID fight in the last 2 years. Over to you, Doc. What is your initial take on your digital transformation in AIIMS?
The digital transformation from the AIIMS, it has started 1988. And when I have joined in 1992, many people, they have talked to me, as an IT person, what we will do in AIIMS. AIIMS is meant for only the healthcare services and research. And when I am unable to convince that, because I am a literate person, I am convinced what I have to do. So this 30 years of journey, because 92 I have joined, and this June 2nd, I have completed 30 years. Anyway, right now we are getting 14,000 patients a day. How to manage? The demand is about 50,000 patients per day. And when demand and supply, it has a lot of gaps, you will face a lot of problems. Whether you will get from a pressure from the ministry, pressure from the bureaucrats, pressure from the own people, we have to make it transparent for this. This IT technology, it will give it transparent to you. If you do the manual, many things manipulated. But when you will do the IT activities, we have done whole activities in the, let's take, patient has to come in appointment based. So there is no manipulation is there. But there is still, we have to see the real situation. You have to take an appointment. Today you are sick, you need the treatment today itself, not tomorrow. In that case, appointment has failed. So anyway, now we have started this journey in 1988. 3 phases of computation have started. Twice we have failed. Right now, third one is continuing it. So the transformations, what we are talking about it, AIIMS is hunger about data. They need data because AIIMS is meant for the research and training. The first objective is that. And they need the data for it. And they need a quality of data and meaningful data. So just now, Dr. Lal has spoken to you. Government has taken a very big steps since 2014. The first EMR standard has come up. Anyway, that has been revised in 2017. Then ABDM plays a major role for us. I think many people, they do not know it. Every citizen is supposed to have a ABDM ID, ABHA ID. That will help you everywhere. Anywhere, any place, you can access your data if your data is digitized. So government is pushing each and every corner, giving the training. Last week, Mr. Sharma was there in Northeast to convince the peoples to adopt ABDM. It is not only the patients. Dr. Lal supposed to have a one ID for his lab. His own technician supposed to have one ID. As a citizens, I have the ID, including if I am giving a service to a patient, that's supposed to be ID. So that the medical record has transparent. If you have gone, let's take one example I'm giving to try to understand this one. Let's take first visit, you have gone to the Apollo. You have registered it. If your record is AV ID, our ID, they have recorded it, you can access anywhere. Then you have moved to the AIIMS, that I want to get the treatment here. Then we can access your record from Apollo and the current doctors, which is from AIIMS, which is giving the treatment to you, he can see your records. So these kind of things, it is available to you right now, which government has created. Next step is, government is creating HIE, Health Information Exchange. In that cases, what will happen? You will get a single medical records for your whole lifetime. So this is the digital transformation, Government of India. AIIMS is working parallelly in that way. AIIMS is working more than the research also. And the one thing I'm talking about, right now I'm talking about the single medical records. Another thing it will come up. We have already, one project is that, it is called Ummeed. You can get it from net also. Unidentified dead body, when this comes to the AIIMS, we are keeping the DNA sequencing and putting in the net. Anybody is find that somebody is missing, we take the DNA samples and match it, and we'll tell that whether he is related to you or not. So this is the first step. So what it happens when DNA will be introduced in your Ava ID, then you will know that a lot of things it will come up. So a lot of big journey it is coming up, and very soon it is coming up, and government is very serious in this regard. Thank you.
Thank you, Doctor. So let's get down to a few specifics. So a digital technology platform, which we call as smart hospitals, gives you a decrease in hospital-acquired infection, which is one of the biggest rots in our system, less than 20% decrease. Avoid what we call as adverse events in a hospital, gives you better clinical results almost up to 42%, improves the diagnosis by more than 30%, decreases human errors by 40%, gives you a better bed and OT bed utilization by more than 50%, decreases misdiagnosis and unnecessary readmissions, decreases what we call as ALOS, average length of stay in a hospital, by more than 1.2 days lesser, and decreases malpractices overall across the board, even in the referral system. What are the key clinical parameters, Doc, beginning with you from my extreme side, what are the key clinical parameters you would pick up? Please request everyone, keep the answers brief to 1 or 2 minutes so that we can cover more and more topics. What are the key parameters you would look at during this transformation towards digital?
So in our case, for example, we were purely looking at data as the driver, right? I mean, we have a lot of data, and what we have done is to streamline that data. In fact, one of the big problems for us in US healthcare system was that there were large chunk of data coming in, but it was not making any sense. It was not giving any output on what needs to be taken as decision making. Now, for example, how did we look at occupancy at the bed? Exactly like you said now, how do you look at looking at the hospital bed being used efficiently? You know, it not only improves the cost, but also helps the resource planning in the hospital, right? May it be nurses scheduling, may it be the, the clinical clinicians.
Yeah.
That's exact. So we started with proving that
So
with
the key
data.
point you're highlighting is bed utilization and optimization of resources. Okay, next, over to you, please. What are the key things which you will look out at during this?
Specifically for cancer patients, we would look at patient-reported outcomes, symptoms,
Excellent.
while they are not in the hospital.
So you're looking
because
at clinical results.
Yeah.
So I must add over here, I have yet to see a single private hospital, without bias, without fear, without favor, a single private hospital in the Indian diaspora which is publishing in an open platform their clinical outcome results. So I am not interested if a cardiac surgeon has done 5,000 surgeries in the last 5 years. That's not important. What I want to know is 1 year, 5 years, 10 years survival, graft survival, adverse effects. In US and Europe, this has become mandatory. I think it's important from us as medical professionals and as hospital chains to publish their clinical results, and this is one platform which enables us to publish this result. There is no harm in being transparent, and what the patient requires is transparency. So what you're looking at is clinical results, publication of outcomes. Over to you.
Dr. Bagai, in fact, the most important aspect here, we said that whatever decision we will take in the transformation, it has to be centered around patient first. That's the core philosophy of
Patient
Marengo
centricity.
Asia Healthcare. So whatever clinical results, I'll give a couple of examples.
Sure.
If I'm looking at a ease of patient getting to the call center and booking an appointment, I would say that is a priority number one. His appointments in time, when the doctor can basically be tracked, is most important component. Average length of stay. Himself getting report in time from the radiology. So this is what we are doing on ground on saying how we ensure that patients' needs are addressed through the use of technology.
Sure.
That's the key important component at this stage.
Okay. Arvind, you know the beauty of Arvind's labs are, if you ask any patient, they say, nahi, hum lal mein kara lenge. Okay, the reason why I'm stating this small one line, which is a feedback from patients who are unknown to us, is credibility. Because you know the standardization of reporting will be maintained whether you do it in Bombay, in Madhya Pradesh, in UP, in JNK or in Delhi. Arvind.
So I'll just give you a demonstration how we started on this journey. Sujata, can I have that one slide, please?
Sure.
So, ladies and gentlemen, let me give you the background. The background was that I had told you that our first, LIMS or Lab Information Management, program was written in 1986. And then we got it upgraded in 1999 from an Australian company. The first one was, written in India with the software programming sitting across me for 8 months. And he didn't know medicine. Obviously, I did not know computers. So now what we did was, in 1999, we changed it to a world-class system at that time from a Canadian-Australian company by the name of Triple G, and the name of the software was Ultra. Now this gave us the connectivity between machines. And we had to bring in, first of all, the Vacutainers, and I'm the guy who brought the first Vacutainer into India, but anyway. And we got the first, the sample barcoded also. So if you look at on your left-hand side, this is going on since 1999. And our lab in Agartala, which is on the left-hand side, the biochemistry analyzer receives a Vacutainer, which has got clear serum on top, what we call the SST tube, or serum separation tube. It is barcoded. The barcode is read by the biochemistry machine. And since there was no optical cable those days, so we had to use the INSAT 1C satellite. God bless it, I hope it's still working. And it would transmit that ID of the patient via the satellite to our main server on the right-hand side at that time in Hanuman Road in Delhi. And the Hanuman Road lab would have already been upgraded by the patient's information, namely the lab number and the test order. Of course, there's so many other things. And it would give, the reply back, host query would be answered by the which test has to be done, and this was communicated in something like 8 milliseconds. So 8 milliseconds one way, 8 milliseconds the other way, via INSAT 3C, which was lying in orbit 36,000 kilometers above the Earth. And the carousel of the biochemistry machine would actually move, and automatic, I wouldn't use the word robotic arms, but automatic arms would, do the thing. So it was completely hands-free. And then we brought in what, Sanjeev is now saying, we brought the accreditation part much later. It is not enough for you to keep on saying that I am the best, etc. It has to be a third party which says that. So we started the accreditation process in India by ISO, by College of American Pathologists, by the NABL, etc., etc. So that is what has given us credibility. And also let me share another, fact of life in pathology, and that is we rarely make any mistakes during testing. All those systems are very much in place, but we make it in the pre-analytical phase. There's a pre-analytical phase, there's an analytical phase, and there's post-analytical. In the pre-analytical phase, I cannot help it if the technician or the phlebotomist puts a wrong label on the right tube. One, God bless him, a patient came to me in the evening one day, and he says, Dr. Lal, we are so happy, we've been coming here 10, 20 years, etc. And, now I've been cured of my diabetes, but my wife has got one now. So his label had been put on his wife's, tube. So these are simple things which make a difference, and you have to be careful of such kind of errors. And post, of course, analytical errors, of course, there's a whole list. So I will not go into all that. But what we are doing now, let me tell you what we are doing is that we have got a data lake vertical which sifts through about 8 or 10 years of our patient's data and tells the patient, well, this is the kind of a problem which you could have. For example, those of you who are from hematology or who are doctors here, so we can tell you straight away from our indices in an RBC or in a CBC that this patient has got probably iron deficiency anemia, and this patient could probably have thalassemia minor. A thalassemia major is, apparent to anybody, but a thalassemia minor is very difficult to detect. So we have got this kind of a, what we call a data lake, and that is, and another new thing which we have introduced now is a digital histopathology. We are the first ones in India to do that. So this is courtesy Philips scanners, and also there's a company by the name of Ibex. It's an Israeli company This reads digitally all your histopathology, what you've been reading for or been hearing about radiology, etc. So we have introduced it for the first time in India. It's done in prostatic biopsies. It is an artificial intelligence system reads it and tells the pathologist that this could be cancer or this could be non-cancer or benign. I think I'll stop there.
Okay. Now, for the person who's perhaps heading the largest number of government beds, I'm going to shift questions from here on. So when you are building a digital smart hospital, it's done in various phases, what we call as wave 1, wave 2, wave 3. To build a smart hospital, put in enhancements, put in transformations, scalability. What would be your key criteria which you will tell the hospital owners or the patrons or investors to choose a hospital information system? So I'm giving from the grassroots level, what would be your decision-making thought processes as to which system to adopt and how would you then make it digital? So let me rephrase what I have said. What platform would you choose and why? And what would you link in with the digital? Please, over to you. And then we'll go in sequence, please.
Yeah. It is a very good question because many people, those who have a small dispensary or a small hospital or any rural place, what kind of solution is required for the IT solution is required.
Please keep it really brief because so that everyone can. Please.
First of all, you have to go through the government guideline. Government has clearly defined that this standard has to be followed. And that standard, you have EMR standard 2017, which has been approved, that has to be followed. Because this is not only the digitization. Digitization is a major challenge is that your security, your privacy, your confidentiality, that is also, that has to be taken care of it. Right now, it is not playing a major role because Personal Data Protection Bill has not been approved yet. When it will be approved, the AVA, another guideline for the patient security, it will come up. So digitization is not a small thing, it is a big thing. Because patient is the owner of the own record, which you are keeping digitally, and the hospital is the custodian of that. You have to understand that one. And you have the responsibility. Any data leakage is there, then you will be in trouble. So that's why you have to follow the strict guideline of Government of India. Preference will be given because many vendors, they come up with you and it will do a vendor locking. It is a big issue for us. I mean, if you have taken a solution of a particular vendor, you are bound to take these solutions for a longer period of time. It will require a lot of investment to switch over from one vendor to other vendor. You have to take care of that. And that is always vendors try to do it. Let's take, they will throw you a very small price of product. The product is very small, you can afford it, you can take it. After that, you are locked with him. And he will charge plenty of money years to years. This is the one of the biggest problems for it. Yeah.
So the point which is being highlighted is that it's better to have a safe marriage than a bad marriage because this is an association you cannot divorce midway of a running hospital. It's hugely problematic to change platforms, especially in IT solutions. Arvind?
So, these things keep on evolving. So in ours is this kind of a, diagnostic line, so it's slightly different than, what we are talking about. But the amount of innovativeness and the new things which have come out are phenomenal. So for example, I just told you, we have the world's largest histopathology load. We see 1,400 biopsies in one day. We have the highest load for even kidney biopsies and are the only ones who have an electron microscope in private surroundings here. So what I'm saying is that this kind of a data and with digital backing here, you can imagine, and with automatic artificial intelligence reading all those kind of things which I just mentioned, prostatic biopsies, now there is another kind of a thing which has come, which is from a company by the name of Kyndryl, which is an IBM offshoot, so which helps us in management of the Microsoft cloud. Because everything is going to be cloud-based, and as you're hearing, that the patient data has to be kept very, very confidential. So there are new guidelines which are going to come out because you don't know what kind of an animal you are, dealing with, and there are people who have hacked into even our systems etc. So constantly it's a battle, you know, how to keep them safe.
Over to you, please.
In Meringo Asia Healthcare, we are in a journey of creating the entire digital network. And I think 3 years' time, we should be the most digitally advanced healthcare system in this country. This I can say. And our decision, coming back to your question, how do you define and how do you decide on that? So we kept 4 parameters for taking that decision. And majority of time when we look at Indian healthcare, people talk about 3 A's, that is affordability, accessibility, and awareness. We at Meringo Asia, we added one more A, that is accountability. So when we are taking a decision on any IT technology, how it is going to make it affordable, how it is going to make it accessible, how it is going to improve the awareness of the patient, and how it will make the organization more accountable. That is, these are the parameters on which we take every decision so that ultimately patient is a beneficiary of that.
I think there are so many HIS systems and they claim they have everything, but I don't see anyone being completely happy with any of them. So I would go, if they meet your top priorities and if they make user adoption easy, you should go with that.
I'll come back to you on that.
Absolutely. I think that's where I would go. It's more about change management, ease of use, how easy it is to be deployed as well, right? And I'm looking at more of cloud first. Like for example, we do cloud first. Multiple reasons to it. We have seen in the COVID that scalability was one of the biggest issue. How do we get there where we are easy, elastic enough to scale whenever we need it, and of course compress, right? And software as a solution based, for example, SaaS-based solutions is what digital transformation is going to drive within healthcare. It's done it for other industries, it's going to do it within healthcare.
Okay. So what you mentioned is actually the key of my question. There is no system in the world which can customize for that hospital in that region for their needs. Yeah. So what you actually have is what we call as hardware, you have a software, and you have a system integrator. A system integrator is called much like an enterprise bus, where you plug in your cable and get that need solution. So there are lots of homegrown solutions which give hospital HIS, which includes linking in finance, HR, marketing, sales. I'll come to supply chain because that's a very important vertical. Outreach programs, man management, hospital security, and so on. And then you have digital platforms. A lot of even national and international companies like IBM, Cisco, Google, and so on are giving this kind of platform. Wipro, GE is giving this platform. So I think it's important that your enterprise bus links in your lab integrated system, your radiology integrated system, your doctor management software, and so on and so forth. So there is no one solution. It's very important to sit with the people who are domain expert in this to decide this. So to give you an example, a 500-bed hospital, a routine HIS, just to give rough ballpark figures, a routine HIS without any taking names of any companies would be approximately 4 to 5 or going up to 5.5, max 6 crores to set up top to bottom of your total expenditure of a project. To digitalize this, you need to go off about 20 to 22 crores. So very often, this gap, this delta gap of adding on another 15, 17 crores hurts the investor and says, why are you putting this straight off? Let's do it later. The reason is later never comes. It's important to digitalize at the time of inception, conceptualization of the hospital, right at the time when the building is being made, with the positioning of the server room, the temperature control of the server room, the layout of the cables is important. And I'll come to the building management system very shortly to highlight these. And we've done an exercise here in Delhi NCR by spending the delta of 15 crores more. Over a period of 5 years, the ROI reaches 98. That's about 19% of return on investment, which is much more than in clinical healthcare. So the way forward is digital.
Can I give one input?
Please,
Yeah.
please.
Anyway, let's come to the government regulatory. Okay. Government has already informed you that your HIS or any clinical system is supposed to be compliant with the EMR standard. Another document, it is called MDDS, metadata and data set, that has to be compliant. ABDM compliance for this, that application is supposed to be passed through the toolkit of ABDM, Ayushman Bharat Digital Systems. If it is there, then whatever your record is generating, that can be shareable. Otherwise, it is not shareable. And government will come with another bill that everybody has to do it, otherwise you will not be in the market, whether it's a government or whether it's a private. So they have to comply these three things.
Okay. Arvind, focusing just on lab, what I'm talking now very quickly, I'm covering more topics, very quickly on telemedicine. Teleradiology, telepathology, various other clinical medicines. What would be the first 4 or 5 key points as to the first 5 top-end users which approach you in this field of telemedicine? That means an online platform.
Yeah, so as you all know now, you know, there is a lot of innovation which has gone on. So we ourselves, right from, you know, having an ERP which is known as Microsoft Exapta and keeping on, you know, making it better. So now we have reached a state that we have our own apps. A patient can have on his app, he can see the cumulative, you know, his blood sugar in the past, you know, 1 year, etc., how high it was, where it is. We have the doctors who are connected with that, etc., etc. We have now kiosks where patients can register themselves automatically, so it saves time. They, you know, now everything is digital. If left to them, they would, you know, they book the home visit of a phlebotomist from the app. The phlebotomist goes there. The report is available into their system in the evening. And many patients have told me that they don't even know, they've never been to a collection center, they've never been to one of our labs. Everything is done at home now. And the thing which gave the fillip to all this was, you know, COVID also. So RPA, what you called a robotic process automation. So this actually helped us, you know, to get the results of the COVID. We have done up till about 20,000 COVID tests in one day. We have done 3.5 million COVID tests in 1 year, RT-PCR. So you have just imagine the amount of data which was generated, and it had to be sent to various government bodies. Yeah. ICMR is one, Delhi government is another one, there's something else, etc., etc. And then we also have a bot which is known as Automatic Anywhere. So this, you know, has saved us by automating all this, it has saved us at least, you know, hiring another 100 people to put the data entry. So that is the kind of, you know, things which matter to us.
I'll shift questions now. A doctor on the move in a hospital is going to have queries. A clinician is going to have questions. There will be matters of clinical care which keep changing dynamically. There's a worldwide study in which every doctor in an 8 hours duty has 11 to 14 questions per day as queries which come in mind in treating patients, and 66% of them go unanswered when he leaves the hospital. The reason is he is not having access to quick answers for multidimensional and dynamically changing healthcare needs. What kind of apps can be used in hospitals to address this, to improve clinical performance of doctors in treating patients?
So there are certain apps which have come up, like UpToDate and other, where most important is that at least keeps doctors updated on things, because that's a major concern, and especially for the and also the concern is that the senior doctors do not have time to spend time in teaching the junior doctors. So I think the self-learning is their tool, and these kind of apps can be of great advantage. And as you rightly said, that none of these questions, because these questions are pertaining to the clinical condition and to the patients. If they are, these questions are going unanswered, it means somewhere down the line you are compromising the clinical care. So very important, very important.
Over to you. Oncology is a major chunk of decision making.
Yeah, but I think if you look at different systems in a hospital space, whether it's HIS, whether it's LIS, RIS, whether it's your back-end billing system, SAP, Oracle, I think the trick in that is if you have integrated systems in the back-end, where you can track the data by a uniquely identified customer ID,
UHID,
then it's just a matter of presenting different views to a doctor, different to an administrator, different to a patient. So the trick is to actually integrating backward. How to present it is a relatively much easier job.
Fair point.
Absolutely. I kind of agree with you, Raj, because I have an example for this, what we have done. Data, again, we brought the data together. Let me give you an example. We have around 700,000 case of strokes in US. And what we did was we took that data and worked on a model which looked at 150 stroke patients, how they came in. By the time the patients came in, we knew what should be the course of action for the treatment. That's how the data is going to drive AI. And we'll see that naturally when the doctors have enough time, it is a better clinical time with them, and patient experience enhances a lot with that.
Okay. I'm coming now to equipment. So when you set up a hospital, let's say again, a ballpark figure of 400 and a 500 bed hospital, an average thumb rule is 1 crore per bed. It could be less, it could be more, depending upon how enhanced the environment inside is. 30 to 32% of your overall cost of project is equipment. I'm repeating again, is just mere equipment. It's very easy for a common layman, non-medical person to say, in that hospital they don't even have an MRI, or they don't have a PET scanner, or they don't have a linear accelerator. The landing cost of a linear accelerator in a hospital in 2022 after customs duty clearance and installation is 26 crores. One bunker, what we make in a basement, is 26 crores. The landing cost of a high-end MRI is 16 crores. So you have to budget it. Coming first to you, beginning with you, what inputs would you give to a hospital administrative team as to what grade, what type of equipment would be required to suit the needs of a hospital in that geographic region?
I see. AIIMS, it works in different pattern. They do not have any ROI. Okay. But you have to convince that this equipment is required. What you are talking about the linear accelerator, we have 3 linear accelerator in NCI Jhajjar. Because we have studied this project, that how many patients will come, how much, what type of patient will come, and what kind of investigation has to be done. So this hospital is made in that way. So that's why, because 5 MRI is there, 5 CT scan is there. So because the 700 beds,
the turnover is so much.
Turnover is so much, and simultaneously, not only that, another cancer center is main hospitals. We also transport this patient to that place also. So the load is there, and but basically, what I have told you, there is no ROI. That's why we can't
Sure.
Yeah.
Arvind, anything which will decide the type and grade and specifications of equipment which links in with the digital platform?
I think this is all taken now. It's all understood. It's going to come with that. The engineers are sitting in Germany, and if your equipment is malfunctioning, you can repair it from there. So all those kind of things have come in. But as personally speaking, when in India, where things have to keep on moving, though we are in Stone Age, but we are already talking about Space Age. So things have already moved on. And I think our line, just because it is more, I would say, for lack of a better word, more quantitative, it was a lower hanging fruit to get involved in the digital world, earlier. So the artificial intelligence, etc. I told you about the IBEX platform, which can scan, thousands of images, digital images in histopathology in seconds and give you a diagnosis whether it is cancer or not. So that is what India is looking at, and because we don't have so many doctors or specialists, there is no other way except to fall back on such technology.
Question to you is, quick word on sensors and devices, be it wearable, be it ingestible, be it tattooed, be it a sensor on a sleeve. How do you capture the data? How does it help the hospital get information to save a critical period during a critical event and a patient reaching a hospital?
So I think this is the most important aspect of, as you said, that the critical event, if you can actually pick that up because of the sensors, that is where you can actually make a difference in trying to save lives. That is most crucial, and I'll give a personal example of this. We set up the eICUs in 2011, where we connected hospital from the Scots Heart Institute to place in Raipur, an hospital in Raipur. We realized when we looked at the data that majority of the mortality or the lack of care takes place in the night times where you do not have a trained staff or a trained nurse during the night times. we were able to pick up the data and the near miss events were picked up and we were able to avoid disasters. So I would say the sensors, devices are the way forward to pick up that. Yeah.
Question to you, Doc. Supply chain management. How does digital healthcare help improve supply chain management?
Okay. I'm going to take an example of other industries
Please,
because I
please
think
go
we
ahead.
need to learn from them. There's a company who owns pizza outlets. Now it's a commoditized product, and the trick is to give a freshest pizza, hot pizza on time, whenever they want, and the demand fluctuates, within a city, different days, different times. So now to say it's a pizza company, but they are actually a platform company. What they have at the back, they know how to source the freshest material in the shortest possible time at the best rate, keeping the inventory low. They know if you have 10 outlets within a city, how to deploy your staff based on where the demand is peaking, so you have right people on in the outlet to serve the right amount of customers. They even hire people in a 5-10 kilometer radius around that, so that whenever you have to deliver, they can commit a delivery promise, right? Now, think about it. They're a pizza company, but now, since they have this operating model using technology in the back, they are, applying the same for a chicken burger outlets. They can go vada pav, they can go dosa, because they are not necessarily a pizza company, they have an operating model behind it. And we've seen it happen again and again and again. Amazon started as a book delivery company, now they want to deliver pharmaceuticals and get into healthcare, right? We've seen in India that disruption happen. So the whole point behind digital transformation is that they have broken the barriers between different industries. If you have a technology-enabled business model, you can cross over the industries and compete with anyone. And if we think we are competing only with hospitals, we are in trouble, because there will be players who have these operating models who will enter in hospital space and compete with this. We've done a brilliant job in bringing the best medical technology in India so far, but we are behind in using technology to meet consumer expectations and evolve better operating models which make you more viable and more scalable.
Great. Question to you, Doc. Error-free medication. 5 or 10 years back, even US, Canada, UK, the third leading cause of death was human error. This technology, in terms of digital platform, decreases this human error to less than 1%. It is called as error-free medication. You have various checks, balances, alerts within the system. If the dose is written wrong or transcribed wrong, or a particular drug is administered with another drug which is contraindicated, quick words on it. Error-free medication, how the digital platform decreases human error.
Absolutely. I can actually, again, I would still go back to my conversation on data, because I'm a technologist, I'm not a clinician, but I can definitely allow and tell you that we have done this, we have seen, because when we looked at our financials, we saw that there were a lot of money which is being gone because of the errors committed by the doctors, right? And we have looked at a couple of that the data comes in, and we look at, and we do alerts. I think that's exactly what, like you said, it's more about notification and alerts when that exact moment. Just a simple question, are you sure, is going to save a lot of energy and money for the hospitals. Just a simple question that, are you sure you want, or do you want a review, is going to make that difference. So workflows, automated workflows and notifications are going to help that.
So the reason actually of addressing this, an extremely important question, is the doses are, say for example in literal terms in our day-to-day practices, 0.015 milligram per kilogram per day. Just please understand how easy it is to make an error in going from one room to another room, from one patient to another patient. Sometimes the doses are 0.001 microgram per ml per hour per meter squared. It's anyone's guess if you can get it always, all the time correct. So these modifications which are made in the IT system tell you that you're out of range in this drug, or the dose which is calculated is an error. So before the patient gets a wrong medication, you're alerted. A quick word, anyone who can take a domain expert on it, how is genomics going to transform the next 10 years? Anyone, whoever wants to take a lead in this.
I can say about it.
So to give you an example, clinically, you will come across n amount of patients. This person is on one antihypertensive, second antihypertensive, he goes to the cardiologist, and a third antihypertensive. It's not unusual, very common. Doses keep going up, blood pressure control mein nahi aa raha. The problem is not of the BP not coming under control. The problem is that person's genomics is not going to help with that particular drug as a formulation salt, because his body is not responding to it. That means you can modify the dose and probably make a triple therapy into a monotherapy if the drug platform which is used is suiting his DNA in terms of genomics. Anyone can take a lead, please.
Just two lines I will tell you about it. The research is going on. In the genomic sequencing, we are trying to predict the early cancer detection and the best chemo it will suit to give the treatment. And this project is going to be completed this August, and the data will come up to you. So that will be in the public domain. We have taken around 6,000 patients. We have got wonderful result, around 72% accuracy is there. Let's see, because this is Indian data, that's why. And we have a lot of challenges are there, because the DNA of a person from north and south are different.
Wonderful. Anyone can take a lead on the
So
next question.
I
Yeah,
can
please.
add my bit here that the genomics is becoming extremely part of our lives, and the future medicine will not have a gynecology ward, it will not have a surgical ward, but it will have a gene ward. The genes would be, the wards, because the same gene is, responsible for, say, ovarian cancer and also for pancreatic cancer. So once you get to know that there are two guys with the same kind of, disease, but if the genetic makeup is slightly different, one chap will be given the medicines already happening, KRAS, etc., in colon cancer. One chap is given the medicine, and for the other chap, you can keep giving him and he'll not improve. So that is what we are, coming down to. And very recently, I think 2-3 days back, you have read about this new drug, dostarlimab. It's more for rectal cancer. This has, for the first time, cured all 18 patients in a small trial. Unheard of, 100% result. So all this is going to get into the genetic part of medicine. So once you get to know what these 18 patients were of rectal cancer, so the genetic testing is going to be done. If those guys have colorectal cancer and that gene is there, this drug is going to be very effective. Right now, it's of course very costly, but then, that's part of the life. Some Indian company will be able to make it.
Just to give you an example which is familiar and top of the head of everyone in this room is COVID. We've lost millions of patients all over the world, and there are 7 major genes which predispose a person towards criticality, ventilation, ICU admissions, and death. And one of the genes is called as XLR7, which causes interferon type 1 deficiency, which is your protective protein. So the gene deficiency causes the less protective protein, causes more predisposition towards death. So I think genes is going to change our way of looking at life and disease and management forward. Last couple of major vertical questions, beginning with you. Building management system. So we create a hospital, we put in an IT platform, we put in a digital platform. Now who's going to think of building management system? Is there anything called as BMS? Is there anyone going to look after the biomedical waste? Is there anyone going to look after the efficiency of lights? Light saving, energy saving, power saving means conservation, gives a better ROI. Anyone's going to look after the leakage and wastage of water? Is there anything going to be on renewable energy or alternative forms of generating energy? What about the HVAC, right? Everyone talks of ACs. I'm not married to Blue Star, but we've dealt with Blue Star in more than a couple of hospitals. Phenomenal platform of an HVAC system of AC. Ventilation is the next buzzword for the next many decades. Poorly ventilated rooms, irrespective of the crowds, you're going to get some infection somewhere. Warming cycles of air are going to be changed every hour. Where is the HVAC placed in the building? Is the building management system going to enhance the hospital security, breakthroughs, pilferages? Over to you.
Great. We at Providence, we had a promise that we're going to be carbon neutral by 2030. And we are actually running this program, as you said, exactly all the parameters which you spoke about. Wastage, how do you manage air conditioning, especially renewable energy, right? We are posed towards that, and we have seen that when you have a centralized system which can actually do this for multiple hospitals, we can actually gain that efficiency. And we are definitely going towards that, and I'm sure that we'll be carbon neutral by 2030.
Okay, next question. Anyone on panel? And then we'll have a few minutes, Sujata, for question answer if the time permits. Home care. Anyone wants to take over home care? Why should a pregnant lady for a routine blood pressure monitoring have to visit a hospital 20 kilometers away? Why would a single person who's physically disabled or specially challenged child be taken to a hospital setting when it is a routine monitoring? Can this be done digitally? Can this be done through a video platform? Can this be done through a smart alert? Can this be done through an online platform in which advice comes? A patient does not necessarily have to travel up and down. I think home care, ambulatory care is an extremely important part. 20% of hospital OPD visits are unnecessary. They can be done from home. It decongests the hospital. It eases the arms of clinicians to spend more time on critical patients. Anyone wants to address home care?
I think I'll come in here. Sure. Now, the variables, as you all know, are a stark reality. I have an Apple Watch. I'm not wearing it right now. It can tell you your oxygen saturation. It can show you an ECG. It can be linked anywhere through your phone. If there is, you can set the critical limits. If your heartbeat is more than 130, 140, your physician is already going to be informed. Second thing is that this is again coming in. You all have heard about it. Internet of Things is 5G coming in, 6G coming in, etc., etc. What does it all mean? That you are going to be living in a wired, actually not a wired kind of a environment, but a Wi-Fi and a Bluetooth kind of a enabled environment where everything from your side can be taken care of. Supposing, we were staying, many of our doctor friends are in America, they tell us that they're worried about their parents because who will look after them? Well, the good news is that a person will go there every day, the data will be available, the doctor would be sitting in the hospital, and all the variables would be transmitting to them what was his, breathing, oxygen saturation, what was the heart rate, ECG, etc. And if need be, the help is always at hand. But again, for India, what we need is a good, electronic health record, and these things will come in later.
Wonderful. Siddhartha, any questions?
Can I give you one?
Please go ahead.
One example I'm giving to you. AIMS, we get the patient from very low level to the higher level people, even the bureaucrats, ministers, and the low class people. Many patients, they come from the Bihar, Assam, Odisha, Madhya Pradesh, Rajasthan, and all these things. We have made a trial that is anti-cognate apps. Okay. For this, there is, it is about 400 patients they have registered, those who are already getting treatment in AIMS. And they have to come every 3 months to follow up for this. What we have done is, we have taken 10 patients again. They have to do that very simple test, okay, RBC and 3 more tests they have to do it. They have to do it, they have to upload the reports. Automatically the apps will read it. If required to visit, then it will tell you, you have to visit it immediately within this period of time. On this day, meet this doctor. Second, if some dosage is required to improve, it is not required to visit, again it will communicate it. This dosage has to be approved. Third one is it is not required anything, then they will ask you, you have to change your food and your activities, physical activities, you have to do it. So this is the things, and it is working perfectly. This is the very small things, but around 70% those who are less than 5, their education is less than 5 standards. So this is the one of the successful example to you. Second thing is that what we are talking about it, we are very serious about to our old age people. They can't move. And any hospital will go, even private hospital will go, at least 1 hour, 2 hours, they have to stay there. But 70% cases, in follow-up cases, it is not required to come to the hospital. They can take the treatment from the remotely.
Wonderful. Just a couple of points. In a hospital, all of us have been to hospitals, either as doctors or as patients. Have you ever thought as to why the first OPD in a hospital block is a psychiatric OPD? Just think why. It need not be so. Why is the last distance-wise from the elevator an OPD of post-op surgical or orthopedics? It doesn't make sense. So hospital planning, hospital alignment in terms of ease of comfort all comes from proper appropriate technology being used to design. I will leave the floor open for any questions. Please ask all the panelists. I'm not going to answer any question I don't know. Please, go ahead. Please.
Firstly, I take the opportunity to thank Dr. Bagai. I think for the first time I'm seeing a moderator who could possibly connect all the dots so beautifully. Thank you, sir. I mean, this was absolutely brilliant.
Thank you.
And the inputs that came from all the panelists, I think absolutely brilliant, particularly Dr. Lal and each one of you. Dr. Rajiv Singhal. My question is that somewhere down the line, sir, when we're talking about high-end agility into healthcare platform, be it through the digital mode or the physical one, the quality of input defines the output.
Yeah.
It could be at the human interface level, where there is a very big challenge that the nation is facing when it comes to skilling of people. Time and again, there are situations wherein right at the hospital.
Can you just pause this question for a second? Because it's something which escaped my list of points to address. And I want to address it to you. Does AIIMS anywhere in India have only for skilled IT development a movement or a center which is giving enhanced level of scientific education to have better trained IT professionals in AIIMS? What we call as skill development?
Yes, skill development, we do it, but
do you all have a certified course, or
no, I
can
do
someone get a qualification from it or a certification from it?
1999, we have started 2 years medical informatics training programs, and that is meant for only defense and railways. We have not opened to the other people.
Back to you, sir.
So the quality of nurses, when it comes to still, I'll go on record to say that I mean there are times when most of the old Kerala nurses used to come, they were much more trained, much better trained, they were much higher on empathy. No biases, but just observation. So most of the time, you talked about the human interface, the human intervention. You said that there are checks and balances into the system. I mean, there were times, and again, I'll take the liberty to say so, that the old doctors, when they used to go on rounds, the senior physicians, the senior consultants, junior doctors would take notes. Now they try to take notes digitally. Half of the things that they say, they never get recorded. And when a doctor is on a round and he has to cover almost about 18 to 20 patients, he's also doing the rounds in ICU. There's a lot of critical data which is being lost. I mean, the changes that are being recommended on the patient bed are not being absorbed by the HIS at all. The struggle to reach out to the people who are serving the diet plans, Dr. has recommended right on the bed something very different, which has not been captured at all. So I think this element of human preparedness, intellect, integration of knowledge, understanding the sensitivity and sensibility alike, where is the skill building for that?
Anyone? How do you capture data in a large, busy hospital where one person is seeing more than 5 or 10 or 20 patients?
I'm not going to give you the answer, but I know somebody who can, and that is Mr. Gautam Khanna, who's the CEO of Hinduja Hospital. Gautam, and he's also the chairman of the FICCI's healthcare committee. Gautam, please enlighten us.
Dr. Bagai, with your permission.
Please go ahead.
So I didn't expect, I mean, you are the panel, you are supposed to answer.
I can ask questions.
Okay, so your point is very, very valid, because in a busy hospital with a senior consultant, the residents would not be able to,
Gautam, bit louder, please.
residents would not be able to take notes like what you mentioned. And so this is a valid thing. So what we have done, for example, in the OT, we have ensured that even if there is a digital recording, they do it there. They don't leave the OT till it is done. But in ward rounds, it is a problem, and some people have started recording on the phone. So I know it is not an effective solution, but this problem has been recognized, and so I gave you an example of the OT, recording notes on the OT. Other thing what we have done is, for the residents, in each ward, we've provided laptops, I mean computers, so that as soon as the senior doctor leaves, and if the resident is there, he just finishes his notes. It's still not the best solution, but I think what we are coming to is, if they can write on an iPad, they write the notes. It's like taking notes digitally, and then it gets converted. So that solution is coming, and we are looking at something like that.
Your point is extremely valid. So this question was actually addressed 5 or 6 years back.
Can I address you?
Yes, sir.
Yeah.
And one of the companies, Philips, has a dictaphone which fits into your coat pocket, and your coats of your doctors is designed that it fits in. It's very much like a pen. It's called as Dragger, right? And it captures through voice recognition what the consultant is saying. So the consultant cannot talk Hebrew, he cannot talk of the weather, and he cannot talk of home and banks. He is talking only of the patient. Is a voice recognition. The voice is converted into a Word document, and it goes into the patient's file before the patient leaves the room. So this technology exists. The question is, who wants to embrace it? It comes at a cost, right? But that cost is negligible when you're looking at data, when you're looking at accuracy of treatment and minimum errors.
Yeah, I can introduce you to some Pune-based guys who are very good at this voice recognition.
And sir, I have one more question. I'm sorry, my mother post-COVID has been hospitalized 9 times in max, so I think I've really faced it. So I think this is not coming as an anguish, but something what I've really felt and realized. So second thing that is felt is that the nurse-to-bed ratio. They say that any nurse is supposed to
Can I
handle-
answer your question, what it is real situation in the clinical system environment? We have a department which is called gastroenterology. Okay, it is a very super specialized department and clinical departments. The first time we have started to make paperless, from the OPD to the discharge of the patients. And each patient's records, which is been entered through keyboards, it has taken 40 minutes, and it was not possible to make it. And who has to enter? Because if you enter by the data entry operator, there is a lot of mistake it will come up.
Okay.
Major fields are drop downs, still something they have to write in running matters. And we have tried for 6 months, we failed. Okay. Next step, what we have done it, offline we have started doing it, but it is not possible. The data is too huge. We have a lot of pendings, it has come up. Next, what we have started, what he was saying, the voice. But the challenges in the voice, one product is very good product. We have tested it. I'll not tell the name because it's a open forum, and I'm not going to promote that product. Okay, but this is a very good product for us. And the accuracy rate is around 94-95%, because medical terminology, it captured, it has a dictionary of medical terminology, it can pick up it. And thing is that my residents are from south, north, east, west, everywhere. Their pronunciation in English is different. Still it captured, because the AI-based voice recognition systems. It's a very good product. And when we have tested it, what was the problem, do you know? In the OPD, the doctor is seated is there. In super specialty, one consultant will be seated there, and one senior resident and 2 junior resident doctors. They have to talk each other, and patient is there, and patient with attendant. And some patients are outside also. So a lot of voice it will come up. So that's why the product is really useful, but when it comes to the practical, it is not useful, frankly speaking. That is the major problems we have. Anyway, we have to find some other solutions. When you are talking about writing, see, there are two things we have to look into it. Clinical system is supposed to be standardized. And Government of India has already recommended you have to adopt SNOMED City. It is the free license to all, government as well as private. All the clinical system is supposed to be compliant with SNOMED City, and SNOMED City code is SNOMED City made for only for the IT digital records, health records. It is for the digital health records. Whatever you will, let's say you are typing the symptom at the background, it will give the list of the symptom. You will select one in background, in digital form it will be stored there. It is not required to remember that code. And if you want this mapping also, CDAC is giving free of cost to everybody. So you should know it and you should apply at your place. Otherwise, any medical record, it is not standardized. You can't use the AI. Because I have 3 projects in AI, I am facing same problem. Because old data is, there is many nomenclature is coming up with same symptom, same disease. So you have to take care of that thing. This is my suggestion to all.
Any other questions?
I'm Dr. Rajiv Kumar Jain. I work for Indian Railways healthcare system, which by the way is the largest branded healthcare system in the country today, right from primary, tertiary, secondary, across the country. The question is to the entire panel and maybe some experts in this hall. When we talk of digital healthcare for healthy future, as we've been talking, do you have any benchmark today or any country, any state or any geographical boundary where digital healthcare for healthy future is being practiced as India is visualizing, like you were talking of Ayushman Bharat digital mission? That's part one. Part two, as Dr. Bagai very rightly mentioned, use of technology for vaccine administration to the level that India has shown in the last more than a year. Do you have any other example in the world where this scale and this technology has been utilized for administration of a COVID-19 vaccine in the world, anywhere in the world? These are the two questions to the panel. And these answers to these questions will determine the future of India's path-breaking leadership role, which very rightly Dr. Lal was mentioning. He himself has been mentioning that he's been leading by adopting and adapting technology for his use in Indian geographical situation. So that's the question to the entire panel. Anybody would like to come forward?
Somebody there wants to answer, I think. You can always give the opportunity to somebody from the crowd. Yeah.
Okay. I have a one-line question, actually.
Okay.
That's very nice.
Okay.
Keep it short. We were talking, Dr. Lal specifically had information or an opinion that you've got Internet of Things, you've got wearable devices, they send data. My question is very simple. Will clinicians act on this data and prescribe medicines or treatment?
Yes, of course, the clinicians would love it. If they don't have to take somebody's pulse, and they themselves, of course, never take the blood pressure, so they would welcome it. They just want data to be presented to them, that this is the patient, these are the signs and symptoms, and of course, unfortunately, we didn't have a IBM Watson kind of a thing here. Otherwise, everything is now in front of you. But I'll tell you the place where they have faltered. The NHS chief was here many years ago, and he said, Dr. Lal, we unknowingly introduced the electronic health records or digitized the whole thing, but we made one great mistake, and that mistake was that we did not take doctors into confidence, and it went haywire, it fell flat. So doctors are very chary of using any system which they themselves don't feel easy with. So that is, India has got to find out, what you want. Apollos will do something else, and Fortis will do something else. Max will come out with another, solution. So you have to wait.
Yeah, so for a treadmill, you have a protocol which interprets the signals, right? For a patient monitor, you know the data is coming off your bedside in your hospital, so you trust the data. Now, there's an Apple Watch, there's an Android watch, there's some other IoT device. These may or may not be standardized. So will the healthcare community accept the data as valid enough to act and prescribe? That's the question.
Absolutely, yes, absolutely.
Sir, one thing I'm telling you, telemedicine standards, it has been already been approved from Government of India. So that you can, what you are asking, all the answer is there. Whether it's IoT device, whether it is a digital stethoscope, whether it is any other devices in that is also, everything is acceptable.
Yeah. Let me, is there anybody from Fortis here today? Okay. So Fortis is already operating remote ICUs, and then somebody else also.
I'm the guy who set up
So
that.
again, I don't know why is he keeping quiet.
2011 was the first time when 150 beds were connected from Escorts to Raipur, Raigad, Amritsar, Dehradun, Agra.
So we have Mr. Rajiv sitting in the panel, we have Raj Gore sitting in the panel, and behind we have Dr. Alok Rai, so all, and myself Vishal Gupta. So there are so many ex-Fortis people are here. So these are the core team who developed the entire Fortis ecosystem long time back. So you can ask whatever you want to ask for the Fortis.
So my simple answer is that when you can run remote ICUs, what you think the doctors will not believe a Apple Watch ECG?
So the good thing is the CDAC, eSanjeevani platform has evolved a lot. So I think if you see that platform, that is giving all the functionality which is required on a scale for the country like India. But I just want to ask, the answer one question which was just asked. So currently I am working as a CIO for a healthcare group, but for last 2 years I worked as a advisor for the digital health for National Health Authority, and I was primarily responsible for Ayushman Bharat Digital Mission ecosystem. So I was the chief architect for that. So 2-3 things. First thing is the government, as Mr. Sushil from AIMS has mentioned, the government is doing a lot of work for the digital health standardization and to build a digital health ecosystem for India. But the sad part is the people are not aware. For example, the CDAC. CDAC in collaboration with NHA, National Health Authority, has published a NRC, which we call the National Resource Center. National Resource Center is giving all the profile for the standardization of the health ecosystem. That is one. Second thing is, the government is investing a lot in terms of the SNOMED city, as mentioned by Sushil. So government is investing, and SNOMED city is available as a nomenclature for free of cost for the public and private, and government is ready to pay for the entire nation for the SNOMED city. The third thing is government has, there was a question that what benchmark we are making. So there is no benchmark actually available for India. And India is creating their own benchmark. And the reason for that is, in other part of the world, see, the issue is there is a kind of a repository of electronic health record, which we call the EHR. But unfortunately, in India, we cannot, due to n number of reasons, mainly due to the PDP bill, we cannot have a centralized EHR. So what we decided is the data will remain at source. The source means the care provider, be it Fortis, Max, HCG, Apollo, or AIMS. The data will remain at the source with the point of care, and there should be a provision so that the data fly real time. So if I am a patient going to Fortis and I have a health records in Apollo, then that is my data, and it should be in my control, and wherever I want, so I should be in the position so that data fly with me. The way I carry my physical file, similarly, I have the control of my electronic health records, and the data fly whenever I want based on my consent. So that framework is very unique. It never happened anywhere in the globe, and first time it is happening in India. So we did pilot in 6 UTs in India. It went very successful, and now recently it has been launched across the India, and that is happening successfully.
May I request Mr. Bibor and Mr. Srikanth to come up on the dais to felicitate our panel members.